Hello. Good morning, my teachers and friends. Today I am privileged to introduce Dr. Kavya Reddy. She is an expert fertility consultant in Ferty9 Center, Vizag. Dr. Kavya Reddy did her MBBS in Sri Devarajar's Medical College, Kolar, and she did post-graduation in DNB OBGYN in Narayana Hridayalaya, Bangalore, and worked as a consultant in Narayana Medical College for 2 years. And Madam did fellowship in reproductive medicine, Craft Konda Gallur, and worked as a fertility specialist in Craft Fertility Center for 1 year in Cochin. Madam is going to enlighten you for ovulation induction and follicular monitoring.
Thank you for the kind introduction, madam. Welcome to the session. We have protocols which is very difficult to understand, but now present practice as an infertility patient walks into our OPD, definitely if we tell IVF, they will run away from us. So depending on the patient and previous history of the patient criteria, we have to choose them what treatment to be given. Most common treatment what we give as a gynecologist is ovulation induction for most of the patients. First, regarding the ovulation induction, we have to know the physiology of ovulation induction when we are treating the patient. I'd like to more concentrate on the physiology and the mechanism of action of drugs, how does they work. So our main aim is development of one or more ovarian follicles so that they reach the stage of maturation for them to become fertilized. And the target is only singleton pregnancy, not the multiple pregnancy, and decreasing the risk of OHSS. So as Subha Madam already told, the ovulation induction, we talk about whether we want monofollicular development or multifollicular development. Definitely it is monofollicular development, but in a patient who is having PCOD, who is having anovulation, where you can see the first slide, when the patient is having anovulation, our target is single dominant follicle. But patient who is having regular cycles with no anovulation, like in patients like unexplained infertility, if we are treating patient for the case of male factor and stage 1 and 2 endometriosis where we are giving ovulation induction, the target will be super ovulation, that is multiple dominant follicles which have to be less than 3. If it is more than 3, we have to cancel the cycle and we have to go for the next cycle. So the important concept for folliculogenesis we have to know is FSH threshold. Like what is FSH threshold and what is FSH window? Threshold is nothing but the concentration of FSH required to initiate the secondary recruitment of the follicles. First, till the small antral follicle, they are all FSH independent. They are growing without any dependence on FSH. Then we have to intervene from day 2 or day 3 of cycle. The FSH will act on this follicle and the follicle will become a dominant follicle. That is a natural procedure. So what is FSH window? The duration of the FSH for which FSH will be above the threshold. That is called FSH window. So the duration of FSH remains above the window, number of follicle will increase. So if you can see this, there are different follicles. In number 7, there are only 3 receptors for this follicle. Every follicle will have different threshold. For example, if a follicle which is having a minimum number of receptors, for 50 international units of FSH, it will increase. For other follicle, the receptors are very less and it will require 150 international units of FSH for recruitment of this particular follicle. So when the threshold is attained, first thing what will happen is the follicle will be rescued from the atresia and the follicle will become selected. That is called selection of follicle, which further become dominant follicle and further it will ovulate. So other follicles which are not meeting the threshold, which are not in the window, they slowly will become atretic. So at the beginning of the cycle, only if the serum concentration exceeds the FSH threshold, follicular development will happen. If the follicles are not, the threshold is not reached, no follicle will be developed. Unlike in PCOD, it is totally different. So this is a spontaneous menstrual cycle where you can see the FSH window. The window is small between the luteal-follicular transition. You can see only one dominant follicle being selected. So when we are giving ovulation induction, our target is to increase the window. So in increasing the window, what we are doing by increasing the window, the number of follicles which are selected to become dominant will be increased. In this slide, you can see the 3 follicles are becoming selected and further they become dominant. Other follicles will become atretic. This is a stimulated cycles. So this is a normal physiology of any cycle. Like 3 months, follicles will be there inside the ovary and they will be waiting for them to be recruited. Okay, after 3 months when they become small antral follicle and when FSH is above the threshold, they will become recruited. So what are the changes you see in a follicle from day 2, day 6? What are the changes? Slowly the follicle will be increasing in size. This is a natural cycle or ovulation induction cycle. The size of the follicle will be increased, which is around 1.2 to 2 millimeters per day. So when a dominant follicle, when we call it as a dominant follicle, any follicle which is around 18 to 22 we call it as a dominant follicle. It also depends upon the which ovulation induction agent what we are giving. So when the dominance is reached, even the vascularity of the follicle, as Sonal ma'am said, it is fully vascular follicle. So what are the ovulation induction presently available? Selective estrogen receptor modulator, clomiphene citrate and tamoxifen, aromatase inhibitors, letrozole and anastrozole. Anastrozole is mostly used in male factor infertility, and gonadotrophins like FSH and HMG. So the next question is what drug to be chosen and what dose to be chosen for this treatment. So mainly individualizing of the treatment is very, very important when we are doing IVF or ovulation induction, anything. So we have to see the age of the patient, what is her ovarian reserve, AMH and AFC, what are the primary cause of infertility and prior response. For example, patient is already been treated and it was found to be clomiphene resistant. We can't give again clomiphene in this cycle also, and we want the ovulation to happen. So we have to change the protocols. So years of infertility also matter, because more than 3 years of infertility, we have to treat them very carefully. Obese patients will respond less with the ovulation induction agents. So how do we select the patient and which patient will have better success rate? Younger patients who are having acceptable AFC and patent tubes with no adhesion, the function of the tube should be maintained with the patency, and male total motile sperm count should be 1 to 5 million for them to have a better success rate. If they are having less success, like it is seen in mostly patients who are having more than 35 years of age, less AFC and patent tube with adhesions. HSG, by doing HSG, we can sometimes even identify the peritubular adhesions, which we can see the loculated form. So these patients, we can, even though the tubes are patent, we can think there is some tubo-ovarian abnormality which is inside their body. This also we have to check. And total male TMSC is less than 1 million. So when should be the first scan be done? So when do we do the day 2 scan? We call it as a basic scan. Why we call it as a basic scan? Because all the follicles will be between less than 9 mm. Any follicle which is more than 10 mm on day 2, what should we do that? We call them as cyst, or we should treat this patient, or we should postpone this patient to next cycle. So on day 2, you can see this picture where there are so many small follicles, antral follicular count. So when a patient who is having cyst, what do we do? On a day 2, there are two types of cysts, as they are inert cyst or active cyst. How to identify them? If you are following the patient in the previous cycle also, you will definitely know whether it is an inert cyst or it is an active cyst. So for the first time the patient is coming and she wants to, like in Vizag, most of the patient will be army patients or Navy. They will want to do treatment only in this month. Next month the husband is not available. What to do for these patients? So we have to have previous history, whether she has taken any treatment in the previous cycle, history of scans in the previous cycle, and go ahead with ovulation induction only when it is inert cyst. How will we know? So for these patients, we can do day 2 estradiol and progesterone. The cutoff what we are supposed to take is less than 70 to 80 picogram per ml of estradiol, less than 1 of progesterone. So for these patients, if the values are met, we can go ahead with ovulation induction in the same cycle. If they are active cyst, definitely you have to postpone the cycle. The ovulation induction don't help in these patients. So what can we do? We can give oral contraceptive pills for this month for 18 to 21 days, and we call the patient for the next month for ovulation induction. In case the patient husband says, I am not there next month, what else you can do? Semen freezing, we can definitely offer to this patient 2 samples, and with that semen freezing, we can go ahead with IUI in the coming next month for this particular patient. So there is a case scenario, a 25-year-old married woman to a 27-year-old man. For past 2 years, they are having regular cycles, patent tubes, and there is normal male factor, semen analysis is normal. So can you offer ovulation induction in her, or should we wait? 2 years of infertility, and it is an unexplained infertility. We have to go for ovulation induction in these particular patients. So most commonly used drug is unexplained infertility. We are targeting at multifollicular development. I would like to go for clomiphene citrate, depending on again age and BMI of the patient. We would like to start 50 milligrams. Or from day 2 to day 7, we are giving 50 milligrams. The follicle again I am checking on day 9 of cycle. There is no dominant follicle. What to do? We have to wait for next month. We convince the patient for gonadotrophins. There is no money. Patient is not agreeing. What to do for this patient? patient, we can increase the dose in the same cycle. That means we have to increase double the dose of clomiphene citrate, that is 100 mg. We have to give 5 more days, and we again check the scan after 2 days. So in the same cycle, if the dominant follicle is not there, again we can increase the dose to 150 milligrams of clomiphene citrate. We wait for 5 days again. So this is called as stair-step protocol. So what is the difference between a single clomiphene citrate and stair-step protocol? There is no difference between ovulation in this particular patient, and pregnancy rates are similar to a normal protocol. In stair-step protocol, we are only decreasing the time period for ovulation and the pregnancy rate. So we will help the patient to conceive in the same, to get treated in the same particular month. So there are few patients where we call as clomiphene citrate resistance. So what is resistance? We are giving 150 milligrams of clomiphene citrate. 3 months we had given for this patient. She is not responding. She is not ovulating. She is not ovulating means it is clomiphene resistant. If the patient is ovulating and not conceiving after 3 months of clomiphene citrate, that call is as clomiphene citrate failure. So what are the other modalities of treatment for these patients? Definitely gonadotropins, but if she is not agreeing for gonadotropins, we have to go for extended clomiphene citrate protocol. So where we give 100 milligrams of clomiphene citrate from day 2 for 10 days of the cycle. So sometimes multifollicular development definitely will happen with this clomiphene citrate. There is one advantage with this in this is you can't see premature LH surge. In all these protocols, because estradiol level is more than 200 for more than 48 hours, you can definitely see LH surge. And we won't be knowing how to talk to the patients. If a patient is coming with ovulation, they'll ask, why didn't you monitor us? So how do we do, what is the advantage of this is, so selective estrogen receptor modulator, it is actually blocking the estrogen receptors in our hypothalamus and pituitary. When receptors are blocked, even the elevated levels of estradiol is not perceived by the hypothalamus pituitary, because of which there won't be any premature LH surge. So you can actually plan for IUI cycle or ovulation induction in this particular patients. So what is the other selective estrogen receptor modulator? That is tamoxifen. We can give to 20 to 40 milligrams per day. The cost of there is only 5 tablets kit. It is around 300. What are the advantages of tamoxifen over clomiphene citrate? It is not having any anti-estrogenic effect on endometrium. So endometrium will be good. And even on the cervical mucus, tamoxifen is not having any anti-estrogenic side effects. So when you compare clomiphene citrate and tamoxifen, what is there? This is a Cochrane review 2016 says there is no difference in clinical pregnancy rate, miscarriage rate or live birth rate when you are using clomiphene citrate or tamoxifen. So both you can use to the patient. So next scenario, 22-year-old girl married to a 30-year-old man. Couple are trying to conceive for the past 2 years. She is having irregular cycles, patent tubes and normal male factor. Her AFC is 12 in one ovary and 14 in one ovary, and AMH is done 8.8 milli-international units per ml. So diagnosis is PCOD. Which ovulation agent is better? Whether you go for clomiphene citrate or you go for letrozole. Definitely letrozole is much better in PCOD patient when compared to ovulation, compared to clomiphene citrate. Live birth rate is higher with letrozole. So when I was doing my PG around 8 to 9 years back, letrozole was banned. FDA banned letrozole. So the reason for banning letrozole is there are few studies which showed letrozole is causing congenital cardiac malformations in the babies. That's why they banned. So later what happened? After actually letrozole is not causing any malformation. There is a comparable study that how much natural conception patients are having risk. Same percentage of risk is seen in the patient who are using letrozole for a ovulation induction. So again, letrozole had become gold standard for treating PCOD patients. Letrozole chances of clinical pregnancy rate will be around 20 to 27%. It causes better endometrium, even the cervical mucus. It has lesser complication because the target is only monofollicular development. Now we have to know what is the mechanism of action. It is definitely aromatase inhibitor. Aromatase inhibitor, it will decrease the estrogen levels in the body. When there is decreased estrogen level, the hypothalamus pituitary negative inhibition is lost. So there is increasing in the FSH and LH hormones from the hypopituitary axis. So, but when the follicle starts developing, when the estradiol start producing around the follicle, it's not the receptor blocks. Unlike clomiphene citrate and tamoxifen, which blocks the receptors, it is only the aromatase inhibition. So the estradiol level will be positive. It causes negative feedback mechanism, and there is decrease in the FSH and LH levels, because of which monofollicular development is seen in this particular patients. So the dose is, so the standard protocol is 2.5 milligrams. We have to give 5 days, and ultrasound will be monitored on day 8 and day 9 of the cycle. higher ovulation rate and high pregnancy rate is seen, and monofollicular development is much better in letrozole cycle. And again, this is the case scenario. 26-year-old female married to 29-year. Couple are trying to conceive for the past 3 years, irregular cycles. And ovulation induction is done with letrozole for 3 to 4 cycles. There is no dominant follicle for ovulation. And can you give ovulation induction for her with gonadotropin directly? Patient, instead of gonadotropin cycle, we can do letrozole cycle. Extended letrozole cycle can be done. Extended letrozole cycle is same like what I have told about clomiphene citrate cycle. You can use letrozole from day 2 to day 10 of cycle for a period of 10 days. Okay, only a disadvantage is sometimes you will feel decrease in the endometrial thickness, but letrozole will act on the endometrium or in our body. Its T-half is only 48 hours. So after 48 hours, after stopping the letrozole, definitely there is a procedure called ubiquitinization where the receptors are more. So when the estrogen will act on the endometrium and endometrial thickness will increase in these patients. There is also protocol where you give high dose protocol. High dose protocol can be directly given in patients who are obese. Definitely 2.5 milligrams won't work for them. 7.5 to 10 milligrams for them from day 2 to day 5 of cycle. It is very good enough in the starting on a first cycle itself. No need of waiting for the next cycle. So again, this like letrozole and clomiphene can be given together. So both the mechanism of action act together will increase the FSH-LH in the body. So how should we give this? Clomiphene citrate 100 milligrams and letrozole 5 milligrams from day 2 to day 7 of cycle, that is a 5 days. So in this study, there is increase in the ovulation rate to about 92%. And clinical pregnancy rate to 31% and live birth rate increased to 25%. So are there any adjuvants or we have to give only ovulation induction agents? Definitely adjuvants have a role in ovulation induction like metformin, glucocorticoids in ovulation induction and oral contraceptive pills. I am focusing on mechanism of action because we should know why we are giving also. So metformin, what is causing it? It decreases the glucose levels. By decreasing the glucose levels, it also decreases the fasting insulin. Or these PCOD patients are having hyperinsulinic state. This insulin will decrease sex hormone binding globulin. So when the decrease in the sex hormone binding globulin is there, definitely androgens will increase. So by giving metformin, we are decreasing the insulin and we are increasing the sex hormone binding globulin, and it also reduces androgens in the ovary, and hence it is very, very easy to do ovulation induction. By giving this, we also change from the androgenic environment to estrogenic environment and better ovulation induction. So whether there are studies which shows even RCOG and SOCG says metformin should be combined with clomiphene resistant patient who are older and having a visceral obesity. That means the patient is BMI more than 30. We need not wait for the patient to be clomiphene resistant and give metformin. We can directly add to this patient who are having visceral obesity and BMI is more than 30. So clomiphene plus dexamethasone. So androgens, actually, when we all know when there is high androgenic environment, the dominant follicle don't develop. So by giving dexamethasone, how do we give this dexamethasone? We start from day 2 of the cycle till day 14 of the cycle we give along with the ovulation induction agents. So how does it act again? So definitely we are giving steroid from outside, CRF will be decreased, and there is increasing in the FSH and LH. That is one factor. When we are giving androgens from outside, it reduces the circulating adrenal androgens, and it also releases the inhibition from aromatase. Release of aromatase inhibition. So that's how the dexamethasone acts. So there is one more adjuvant where patient is continuously having no dominant follicle, anovulation. So these kind of patients will be having increased LH levels if we are doing LH and FSH on the day 2 of cycle. These particular patients will definitely benefit by giving oral contraceptive pills for a period of 2 months, that is followed by ovulation inductions. So when we are giving oral contraceptive pills, because these PCOD patients are only mostly resistant patients. So we have to very be sure the patients are not having any metabolic syndrome components. We have to rule out hypertension, hyperlipidemia, diabetes and obesity, and we have to always ask the history of deep venous thrombosis in these patients when we are giving continuously oral contraceptive pills for a period of 2 months. So coming to gonadotropin in ovulation induction, directly gonadotrophins can be given in a patient who is more than 35 years of age. If the patient is clomiphene resistant or letrozole resistant, hypogonadotrophic hypogonadism patient, and unexplained infertility patients. So gonadotrophins, we have to use these gonadotrophins very carefully because of the increased risk of multiple pregnancy and OHSs. Significantly, intense ovarian response monitoring is very much required, and we have to have a proper cancellation criteria so that we will stop the treatment. Disadvantages are it will add cost to the patients. So what are the dilemmas when we are giving gonadotrophins? Again, what is a basic dose to be given? What is whether FSH or HMG to be given, or recombinant or urinary products we should give, or what are the different regimens and dose changes we have to go to direct gonadotrophin patients? So when we are comparing FSH versus HMG, there is no difference in clinical pregnancy rate according to Cochrane 2011. So we can give both FSH and HMG for ovulation induction. FSH or urinary gonadotrophins, there is no difference in clinical pregnancy rate. So either we can use. So the one more thing, when you're using gonadotrophin, there are standard gonadotrophin protocols where we should give daily gonadotrophins or alternate day gonadotrophins. Definitely, when daily gonadotrophins is given instead of alternate day gonadotrophin, there is increase in the clinical pregnancy rate which is observed. So there are different types of protocols like gonadotrophin protocol, step-up protocol, step-down protocol, and sequential step-up and step-down protocol. Most commonly used protocol by all of us is oral ovulation plus gonadotrophin protocol. So in this protocol, we start from day 2 of cycle for 5 days of letrozole or clomiphene citrate. After that, from the next day, we will be giving FSH or HMG from 37.5 to 75 international unit depending on the weight of the patient and her antral follicular count. So we give trigger only when the follicle is around 18 to 20 mm. HCG trigger can be given, and after 36 hours we go for IUI. This is most commonly followed protocol in PCOS. This is a standard step-up protocol. The target of this standard step-up protocol is to find out what is the freezing dose. What do you mean by freezing dose? That's the dose, that means freezing dose is nothing but the FSH threshold for which the follicle started reacting. So we give 75 international units per day. We give it for a period of 7 days. Then you do the scan. In the scan, the dominant follicle, what you should observe is more than 10 mm. If there is no 10 mm dominant follicle, we increase the dose to either we can increase 50% of the dose or you can double the dose. So that you can, on doing scan, we can identify, if not even a single follicle, every follicle is less than 8 mm, you can double the dose. If you are finding any 9 mm follicle which is ready to be crossing the threshold, we can increase only 50% of the dose. That means we are already giving 75, we can increase it to 37.5. And on day 12 also I had seen there is no dominant follicle. We can increase up to 225 international units per day. So when the follicle of more than 10 mm you found, we have to freeze the dose and we have to continue the same dose. So with this protocol, there is high incidence of OHSS which is seen in around 7 to 14% of cases, and multiple pregnancy rate is more. So unless in this protocol, unless the FSH threshold is crossed, folliculogenesis doesn't begin. So continue to give gonadotrophins till the dominance is achieved. So this is a low dose, chronic low dose protocol. The only target of this protocol is monofollicular development, because we are persistently giving the low dose. We are not going to give 225 like that. We are giving 37.5 or 75 international units. So depending on the patient, the low dose protocol can be tried from 7 to 14 days. Like 7 days you give the same medicine, or sometimes we give in hypo patients we can at least give this 14 days also to see the dominance. So after this we have to increase the dose by 50 to 100%. Disadvantage is it will longer duration of gonadotrophin. They have to come to the hospital multiple times. The cost of the treatment is more, longer treatment duration. So all these protocols we are mainly targeting at fixing the threshold dose. Once the threshold dose is met in this particular cycle, for example, patient has come in July, we have a target dose has been found. Next time when she's coming, next month in August day 2 when she's coming, we have to start with the particular dose where the freezing has been reached. Standard step-down protocol, it is like there are many disadvantages of this protocol. Directly we are going to target many follicles. We are increasing the FSH threshold of many follicle by giving high dose of gonadotrophins. 225 international units of gonadotrophin we have to give. Like instead of measuring 7 days, it is for controlling the ovulation stimulation. We can call the patient on day 4 of cycle to see how many follicles are becoming dominant. And for the same, like we have to freeze the dose on particular day where the dominant follicle has been reached. So we have to also monitor in this protocol. Estradiol monitoring also is very good, and serial ultrasound monitoring has to be done so that we avoid multifollicular growth development, and we also decrease the cost to the patient, because we give 225 and we can't say the patient so many follicles have come. So depending on the weight, as I said, the patient should be, we have to choose the patient and we have to choose particular doses this patient so that the chances of cancellation are less. So after all this protocol, which is better, whether you go ovulation induction or you go only gonadotrophins, or you want to mix the protocols with ovulation induction oral agents plus gonadotropin protocol. By giving only oral and agents like clomiphene citrate and letrozole, sometimes we may not be reaching dominant follicles. Patient won't be waiting months together for dominant follicle appear. So combined protocol, we have better clinical pregnancy rate. In letrozole and HMG protocol, the clinical pregnancy rates are 20.5% when compared to clomiphene citrate and HMG protocol, which is only 12%. So cycle cancellation, the target of cycle cancellation should be 15 mm follicle. If it is more than 3 follicle, 15 mm, cancel the protocol. We ask the patient to come next month. And we should always tell them to use contraception when to prevent a multiple pregnancy rate. So the monitoring of the follicular monitoring has to be done depending on the growth of the follicle every third day or every second day. The growth of the follicle is around 1.5 or 1.2 to 2 mm. Depending on that, we call the patient alternate days or 3 days once. And when to trigger this patient. A dominant follicle, clomiphene citrate or gonadotrophins, it is totally different. It will be told later. Endometrial thickness is also important when we are doing ovulation induction and IUI protocols. If the endometrial thickness is less than 7 mm, the clinical pregnancy rate does drop because the implantation will change in this particular patient. So what kind of trigger? You give only urinary HCG or recombinant HCG or recombinant LH, gonadotropin agonist or dual trigger. So most of the times HCG 5000 to 10,000 international units does work. In case patient is not having ovulation or unruptured follicle syndrome is found in this particular patient, we can go for GnRH agonist trigger and dual trigger also. Only disadvantage of GnRH agonist trigger is what will happen with this trigger? It will cause luteolysis. The corpus luteum has to be maintained for about 14 days for the placenta, for the pregnancy to form, and later the placenta has to take over and start producing the progesterone. This gonadotropin agonist, which causes early luteolysis. When there is early luteolysis, there is no support of progesterone. So when you are giving gonadotropin agonist as a trigger for ovulation induction, we have to supplement progesterone like luteal phase support, either vaginal progesterone or duphaston from outside. Dual trigger is mainly given in patients who are having LU of luteinized unruptured follicle. This can be given 0.1 milligrams of decapeptyl or 0.1 milligrams of buserelin along with HCG 5000 and 10,000 we can add to these patients. Poor endometrial development, we have to keep in our brain not only the follicle, we should always see the endometrium for when we want to go for a better pregnancy rate. So endometrial thickness target is more than 7 mm, less than 7 mm there are less chances of pregnancy. So if the patient is having less than 7 mm, when to start estradiol valrate, whether we should start from day 2 of cycle or mid of the cycle we have to start. It is very, very important. You can't start estradiol together on day 2. So as I said, the mechanism of action what we are targeting is increasing in the FSH. So for example, this is letrozole and progenova given on the same day. Like day 2 patient had come, we had given letrozole. We have also started estrabet on the same day. So we are not, the proper mechanism is not happening inside. You are giving letrozole to increase FSH. You are also giving estradiol to decrease the FSH. So letrozole should not be given with progenova together from the day 2. So first you give letrozole, you see the dominant follicle. If the endometrial thickness is less than, your target endometrial thickness is not coming, when the dominant follicle is more than 14 mm, that's when the estrogen should be supplemented because the threshold of this particular dominant follicle is already met. So this dominant follicle which is already been recruited, it won't decrease in size or it won't slow down. Okay. So once the dominance will happen, the threshold FSH will act on this particular dominant follicle. The estrogen has to be supplemented that time, whether you give estradiol valerate 2 milligrams BD or you can use TID depending on the endometrial thickness. Sildenafil don't have much role. Sildenafil causes giddiness. So if we want to give sildenafil 25 milligrams per day, we can give vaginal sildenafil so that the patient won't have any giddiness. So thin ET does decrease, it's the follicle what I spoke only. So if, as I told already, if you are using letrozole, wait for 48 hours for the endometrial thickness to increase. Coming to the success rate, whether you clomiphene IUI, there are 8 to 10% of the success rate. We are giving letrozole with IUI 10 to 12% and clomiphene citrate with HMG 10 to 14%. If you are using only gonadotropin with IUI, the success rate is definitely more when compared to the previous 3. But definitely it will be associated with multiple pregnancy rate and OHSS rate as well. So we should only choose the protocol for our patients. Thank you everyone.
Thank you, Kavya, for the elaborate, extensive ovulation induction. It made my head go round and round.
I was fast.
Because I'm basically an obstetrician, more interested in obstetrics than inducing, pregnancy. At the most, I treat the patients with clomiphene citrate and letrozole. If they don't conceive within 3 to 6 months, I'll send them away. I'm a marshal of population control.
Oh,
Okay, thank you.
okay.
I have a question, Kavya.
Yes, madam.
We are not able to keep up with your speed. And another one is clomiphene citrate has anti-estrogenic effect on endometrium and cervical mucus.
Yes.
Previously, we used to give estrogen for that. Now, are you giving routinely tamoxifen with clomiphene citrate?
No, madam, no need of giving tamoxifen.
For,
Clomiphene
then
citrate,
anti-estrogenic effect, anything you are giving?
madam, we are giving clomiphene only for 5 days. Okay, after.
Tamoxifen you mentioned, no, that you are giving along with clomiphene or separately?
Separately, tamoxifen given separately. No need of clubbing with clomiphene citrate.
And follicular study, I thought we will be doing only during 10th to 16th day. Day 2 follicular study, is it necessary for all patients?
Yes, day 2 is must and should for all the patients, because if you don't evaluate the patient on day 2, you don't even know the ovulation induction is going to work or not. If already cyst is there on day 2, on day 10 or day 14 she is coming, we will think it is a dominant follicle and we will give ovulation. And most of the time ovulation scans also we won't do. We will ask the patient if ovulation will happen, we will send the patient. So ovulation scan is also must to at least to ourselves and patient also. We have to know whether she is ovulating or not.
Oh, thank you.
Yeah, I think about GCSF and luteal unruptured syndrome, we are covering detailing in the panel discussion. But since Madam has raised the point as well, most of the studies when endometrium is thin, we always feel something we have to do because we can't go ahead with the thin endometrium. All the studies, if you say, there is nothing significantly which can increase the endometrium. As she told, estrogen has a role after the follicle has become dominant. Once the follicle has ideally what exactly happens is, if you go in a deeper way, if a follicle is secreting 250 picograms of estrogen, compulsory endometrium should be 7 mm, ideally. That much of estrogen, normally, forget about giving any medication, in natural folliculogenesis also, follicle which is 18 mm has 250 picograms of estrogen secreted. This estrogen is good enough for the endometrium to catch up for 7 mm. So, in a way, if you want to see who is the culprit, is it the follicle or the endometrium? This is one single test. Most of the time, I am not a fan of doing more tests. But before putting a woman to hysteroscopy, thinking about any intrinsic factor of endometrium, this one single test will tell us. Because what she's told was day two scan, I can understand as a gynecological perspective when you're so busy, patient comes on day 5, we start. But ideally what can happen is on day 2, there is already a cyst sitting there, which is secreting hormones. It may be 14-15 mm. We start medication, we don't do scan. She comes on 8th day or 9th day. We see that follicle which was already on day 2. And we get confused. We think, okay, this follicle is, it is dominant and we give gonadotrophins. Again, this follicle is very culprit. It even grows actually. It becomes 18 mm. But it doesn't have a receptor. FSH receptor, LH receptor is not there because on day 2 itself it's a cyst. So any follicle which has LH receptors only can trigger. If you give HCG, this doesn't ovulate. Then what do we think? It will become a follicle unruptured syndrome, we call it as. So ideally, if there is a luxury of scan, doing day 2 scan is good. You can rule out many things because as she said, every cycle it's a new cycle. Cyst can come anytime. This happens especially in a POR. Ladies, very few follicles you see on day 2 already there is a recruitment. So having said and done, aspirin, ecosprin, there are all roles for estrogen. About GCSF, when we see many studies, some of the latest studies support role of GCSF for endometrial thickness as well. So if we have tried everything and if it has failed, before going for a hysteroscopy, we can try a method doing a GCSF and also doing a estrogen level, just to see where we are. What about the aspirin? Yeah. Madam, once endometrium, because these are all cost-effective treatments. What is there? Why don't you give aspirin? Give aspirin. We do give aspirin if there is endometrium.
Sometimes it is
It helps. Yeah, definitely. It's a vasodilator and it gets increases the circulation as well.
Can you tell us protocol in PCOD, induction of ovulation? In PCOD, severe PCOD.
Severe PCOD, first, if patient, I have to see the history, whether she's coming first time to me or previously she's already been treated somewhere, what is the age of the patient. So for the first time she's coming, I'll definitely put her directly on ovulation induction. I would like to do, sir, I won't do 2.5. Seeing the patient, I'll go for 5 milligrams to 7.5.